Welcome to Rebel Nurse, the podcast that's here to show you just how bold and diverse the world of nursing can be. I'm your host, Erica Browning. Whether you're curious about unique career paths, need a dose of inspiration, or just want to feel seen and celebrated, you're in the right place. So grab a cup of coffee, an energy drink, or whatever keeps you going, and let's dive in. Hi, Tranise.
Hey there, Erica. How's it going?
Good. How are you?
I'm doing well. Can't complain.
Well, I should let everyone know that we were full on talking about all the good things. We hadn't even pushed record. We were just having a good time having a conversation.
Absolutely. Absolutely. Well, I really appreciate you and your time and allowing me to be here.
Well, let me introduce you really quickly and we'll get into all the good stuff. This is Dr. Tranise Goodlow, and she is a doctorally prepared cardiac nurse practitioner. And she's going to tell us all the things, all about it. And then we'll just get started. But what I want to ask you first is, where are you from?
I am originally from New Orleans, so all about the good food.
Yes, I've never been there. I've always wanted to go. I want to have a beignet. I want to have all the food. Okay, so you are from New Orleans. Where did you go to nursing school?
I did undergrad at Southern University. That is in Baton Rouge, Louisiana.
Baton Rouge. Okay.
We won Nursing School of the Year back in 2010 when I graduated of the state. So
Really? Is that a private school?
it's public and it's HBCU as well.
What is that, HBCU?
Historically Black College University.
Okay, got it. Cool. Is it its own thing, or is it connected to like a bigger university or anything like that?
They did have like a separate New Orleans campus, but that had since shut down. So it's really just Southern. Yeah, we're the best marching band in the land.
Oh, are you the one that I see everywhere? I mean, tearing it up.
Yes, that would be us.
If you don't like that marching band, I don't want to know you. It's the coolest thing ever, and it's so special. Were you in the marching band?
Oh, no. I wasn't in the band, but I'm, Southern blood. I get to claim the band. So
Yes, you do. Yes, you do. My sister was in the band in high school. I wasn't, and she played the French horn. And let me tell you, I can only imagine the workload of that band, because her band, I mean, they were a marching band, football, Texas. They did all the thing. They were doing two-a-days just like the football players in August, and where it's freaking hot. And I know it's hot in Baton Rouge. It's just as hot as it is in Texas. Out there for months and marching. And then all of the added pageantry of like your band. I mean, that has to be like a year-round thing. I mean, we're totally getting off of nursing, but I love this stuff. Okay, so anyway, that's where you went to nursing school.
yes, that's where I did undergrad.
That's where you did undergrad. Okay, where are you now?
Presently, I live in Irving, Texas. So shout out to DFW area. So yeah, I live in Irving specifically. We've been out here since 2012. It's hard to believe, but yeah, we've been out here for a minute now. So
Nice. Well, I requested that you come on now because this episode is going to air in February, and that's American Heart Month, and you are a doctorally prepared cardiac nurse practitioner, and this whole podcast is about all of the cool things that you can do with your nursing degree. And admittedly, like, this is down the line. You have been a nurse for some time. You've gotten your master's. Do you have your DNP?
I do not have my master's. I did a program that was bachelor's to doctoral. So no master's. I have a bachelor's degree and I have my doctoral degree.
Okay, that's good to know. Well, then let me just turn it over to you, and you tell us, start with your first nursing job and go from there. I mean, you don't have to give us every little detail, but, how'd you get started in cardiology?
Wow. So it's funny. I tell this story to my clientele. First job, fresh out of school back in 2010, and I'm aging myself here. Chabert Medical Center, which has now since been bought out by Ochsner. Anybody down in the bayou knows what I'm talking about. One night, patient was having chest pain. We had to get an EKG on them. I was a brand new grad. We had got the EKG. I didn't know what I was looking at. I asked my preceptor, and she was very much like, I don't know. Nurses don't know how to read EKGs. So another side story, I'm an athlete as well. So I'm competitive. And so it kind of struck me, well, wait a second. Nurses don't know how to read EKGs. Well, I'm going to be a nurse who can read EKGs. Like, the competitive spirit in me just kicked in. And so we had a teletech on the floor. Her name was Rachel. Fantastic lady. And she kind of adopted me and she took me under her wing. So at 4 a.m. every night, she would summon me and I would read all 32 strips on the floor. And that's kind of where all the EKG got started. Now, of course, this is telemetry strips, not full-blown 12-lead EKGs, but I'm immensely grateful to Rachel, and I've told her that since. because she really got all of this started for me. So fast forward, had a couple jobs in between there. My last job as a floor nurse. So this was 4 years into my career. And I was that nurse who was drawing pictures on the whiteboard and teaching the patients. And I was precepting new grad. Like I was that nurse on the floor. And so one day I had a patient. They said, oh, her telemetry's fine. She's fine. But I looked at the telemetry monitor. I thought it was a first degree AV block and a bundle branch block. Now, back then, I didn't know a left bundle or a right bundle. I just knew something was wrong. Checked on the lady. She was fine. Vitals, like nothing was wrong. It was just I didn't like the telemetry strip. Long story short, we ended up getting cardiology involved, got a stat 12 lead, told him, hey, look, the 12 lead looks like what I just told you. It doesn't look like her admitting EKG, which was fine. He came up, ended up taking the lady off the floor. I never saw her again. But I saw him in the elevator a couple weeks later, and I said, hey, whatever happened to that lady? And he was like, oh, yeah, I know who you're talking about. She had a small heart attack, good catch. And he walked out the elevator. Like, it's like, she had a heart attack? Because we were 24-hour telemetry, no less, but still, we don't do drama, right? You're going to get transferred to the unit. You know what I mean? After that experience, it just inspired me to just adopt the strips. And I was grateful for the little knowledge I had to stop her from having a major heart attack and potentially having to code her on our floor. And so after that, I just got kind of juiced. I left that job and went to grad school. So that was in 2014. Did grad school, graduated in 2017. I did my doctoral research in hypertension management, specifically with JNC 8, recommendations 7 and 8. They basically say like first line interventions for African Americans should be a thiazide diuretic. And most people were getting beta blockers, which is incorrect. And then, of course, that population has problems with hypertension anyway. So I won an award at graduation, and I was subsequently nationally nominated through ANCC for my research. I didn't win nationally, but I was nationally nominated. Took boards and then started practicing as a cardiology NP, outpatient, and loved it. Loved it. Loved the hypertension, loved the lipids, loved the heart failure, loved the coronary disease. Oh, you're having chest pain in the office. Okay, let's get a 12 lead. Let me do that. Admittedly, though, I wasn't completely happy at the practice for a couple of reasons. Number one, I was severely underpaid. And I think a lot of people can relate to that. I was severely underpaid. And so I took an adjunct job, and because I enjoy teaching. So really felt fulfilled as a teacher. They would let me teach whatever I wanted once a term. And I taught EKG interpretation, of course, or hypertension or lipid. It was going to be cardiology, right? And so my students, they were like, Dr. Goodlow, this is such good information. Thank you. And they inspired me. So I tried to go to the dean and said, let me head up an EP course. Because I had an EP course when I got my doctorate, which I know was rare. I'm finding it out. It's rare to have an EP course in grad school. I'm contacting the dean and I'm getting ignored. And so that was in summer of 2021. And that was a pivotal moment in my career and it really changed the trajectory of my career because that's when I started Dr. G, the NP. That's when I started developing my courses. That's when I started trying to teach colleagues and really create the platform that I have today. So without her rejection, you and I wouldn't even be talking now because I wouldn't even have the platform.
Well, it's so interesting because you and I were chatting about this before, and that in nursing school, I mean, it's talked about loosely, but there's no focus on it. I remember I started in the ER in Washington Hospital Center in DC, which has a very high African-American population. And the number one problem with specifically African-American men is hypertension. When you're going to go to the ER, part of our orientation was an EKG class. But other than that, we ER nurses think we know everything. We will tell you we know everything, and it's not the truth. The truth is, in the ER, one of the benefits is you have a lot of backup. So even if I get the 12 lead, I'm going to go take it to the doctor immediately because that's part of the hospital policy is that they have to get an EKG within so many minutes and a doctor has to, or another provider has to read it within a certain amount of time. So even if I miss it, someone's going to catch me. And so it's different than maybe the nurse on the floor where they feel like they don't have that access to a provider right there. So they feel a little more uneasy. And so we were talking about, you started these EKG classes to fill a gap, but maybe that gap should be filled further into nursing school.
You're definitely reading my mind here. I just believe in, number one, when you get an EKG, there's a lot to look at. It's overwhelming. And if no one has sat you down and say, okay, look at this, and then this, and then this, and then that, you just get overwhelmed and your confidence goes down and then you're in avoidance. So I want people to embrace it and I want it to be fun. I like to tell stories and give analogies and talk about weird stuff, entertaining stuff, but weird stuff. And it's attention grabbing. So I have cartoons.
Yes. Well, I love that you were like, I don't know this. And instead of avoiding it, oh, no, no, no. I'm going to become not the expert EKG reader, but I'm going to make myself better. And I'm going to take it upon myself to get better and then help others get better. I like that attitude in general, even if it's like making a steak. I'm terrible at cooking. If I don't know how to cook a steak, I'm going to get better at cooking a steak. But anyway, so that is so cool. So you knew the track that you took, was it specifically prepared cardiac nurse practitioner, or was it a general nurse practitioner?
So interesting story. When I applied to grad school, I only applied to 2 schools. I applied to the one I went to, University of Arizona, and the other one was South Alabama. Sounds right. I picked those 2 schools for a particular reason, but South Alabama, I was very interested in because they had a cardiology specialty within the doctoral program. And U of A did not, but that didn't deter me because I knew I was going to do my research in cardiology. But my preference actually was to go to South Alabama, and they rejected me. And U of A did not reject me. Well, here we are.
I'm going to walk through the door that's open and, oh, what's going on over here?
Right. Technology.
Okay, this is the door that's open. So you walk through it.
Right. Absolutely. But I didn't let that deter me because, like I said, I knew I was going to do cardiology. I was a telemetry nurse on the floor having lessons in the patient's room. I never forget I had a patient, he was passing away and it was from heart failure, and explaining the underlying pathophysiology that, his heart is weak, so fluid's getting backed up. That's why he's gurgling, and, that sort of thing to the patient's wife and whatnot.
So when you graduated from the DMP program, did you go to Bedside? What did you do next?
So I went straight into outpatient cardiology. I was in outpatient cardiology for nearly 5 years. And so that's where I learned so much. Gosh, I learned so much. I was only nurse practitioner there. It was myself, 2 interventional cardiology, and 1 electrophysiologist. And I saw all of their patients.
So this is like a clinic setting, people who have pacemakers or heart failure, and they're coming in for checkups.
Right. Or we would have acute things happen. I'd have someone come in and say, oh, I'm short of breath. Or someone would be having a STEMI. And so the cardiologist would have to leave, and I would absorb clinic, or as much as I could absorb, because if I have my own clinic, I can't take over all of his, but you know what I mean? Just do what I can do. But I think there's a misnomer out there that if you work outpatient, you don't deal with acute situations. But I can tell you that's not the case. There's been many a time where patients have refused to go to the hospital. And it's just kind of like, okay, well, we'll do what we can do. And we're not a hospital. But I remember a patient in particular. He was in our office. He was short of breath. He had gained like 20 pounds or so. It was fluid. He was in heart failure. And I told him, I said, I want you to go to the ER. I'm going to call ahead and give him a report and let him know you're going. He refused. He says, if you want me to go to the ER, it's not happening. He was so adverse to hospitals, he refused. And so he's like, I will do anything you want, but go to the hospital. So I had to meet him in the middle. He was already on Lasix. We ended up giving him metolazone every other day. He had to come back and see me within 5 days. So I gave him 2 doses of metolazone, told him to get his BMP, his pro-BMP again, and then come back and see me. So obviously we charted that the patient refused to go to the hospital, but he refused. So that's what I had to do. So that was, in my opinion, certainly an acute situation. He ended up losing like 10 pounds within the 5 days. It happened on a Monday and he came back on a Friday. And he did his labs. I told him I want labs on Wednesday evening. He did everything that I asked him to do. He just refused to go to the hospital.
I was going to say, so do you all have nitro paste?
Oh, absolutely. There were many a day that I was standing with the patient, having the EKG machine on and giving people nitro. So like I said, I think it's a kind of a misnomer that, oh, you're outpatient, you don't deal with acute situations. We've had some codes in the clinic. That's happened before too. So we're obviously on the patient doing chest compression. So you do have to be ready. Of course, it's not an ICU, but again, things happen very quickly. So
yeah. Okay. And so you were 5 years in that outpatient setting. What'd you do next?
So when I was in that particular role, interesting story, I had kind of befriended a sales rep, which shout out to sales reps. So I know a lot of times they get a bad rap, but I loved my sales reps because they kept me up to date on the new medicines that were coming out. I liked it. I thought it was great. And I really wanted, and I did have great relationships with my sales reps. So anyway, there was a particular sales rep from Johnson & Johnson, and we had kind of taken a liking to each other. Her daughter played college basketball. I'm a basketball player. Like, we just kind of vibed together. And she called on me for 3 years. And she would bring us Xarelto and tell us about, things and whatnot. And so one day she comes up to me. She's like, hey, have you ever heard of a position called a medical science liaison? And I had been, because my first year as a nurse practitioner, I had met my first medical science liaison at Novartis, and he was trying to recruit me to come work with him. But I declined because I said, no, I'm new. I want to learn cardiology. Right. So you don't need all of that. But at the time, I just wasn't interested. But at that point, I was looking for a shift. And so she's like, there's an opening in North Texas for a medical science liaison position at Johnson & Johnson. Would you be interested? And I said, sure. And she referred me. I got an interview and I was hired. So for those people that do not know what a medical science liaison is, you are the therapeutic lead and the medical expert in whatever therapeutic area that you represent. So use myself as an example. I was hired by Johnson & Johnson within the cardiovascular and metabolism division to be the medical expert of anticoagulation. And so I had a territory, and I would go talk to healthcare providers, and I would go to conferences and get insights to hear what the field was talking about. And I would educate on Xarelto. Example, Xarelto has 11 indications. Many people don't know that. So answering questions about that. Very, very scientific. Very scientific.
So did that job require an NP, or could a regular nurse do that? Or what were the requirements of the job?
That is a great, great question. 90% of medical science liaisons are actually PharmDs.
Oh, okay.
They're actually PharmDs. After PharmD, the next highest degree, if you will, are actually PhD holders.
Okay.
Then after that, it's like MDs, MPs, that sort of thing. So traditionally, because it's pharmaceutical and knowing like PK and PD stuff and all of that sort of thing. But I will say at Johnson & Johnson, they were very interested in getting more of a provider's perspective. And so I became very attractive. My research became very attractive. I had already done cardiology. I had already been a professor. I didn't mention that, but I was a professor as well. So all of that became attractive. And so I got the job. I guess they liked me.
Well, it's just yet another way to use your degree. If you're a nurse, and you're like, okay, I want to do more cardiac stuff. Maybe you're a cardiac nurse already, and you're like, I'm ready to move on. I think I want to become a nurse practitioner and specialize in cardiology. Well, does that mean I have to be at bedside all the time? Does it mean that I have to be in a clinic all the time? No, you can be an educator of sorts. You can work for Johnson & Johnson. You can be in research. There's the reason the whole podcast exists, is to show you all of the ways that you can use your knowledge. Okay, and so you really liked that job.
It was okay. I'm generally pretty happy as long as I'm teaching.
Okay.
Again, there's good and bad to all career choices and whatnot. I can say personally, for me at times, it felt a little salesy that I didn't appreciate, even though we were on the medical team. But again, if you're in the pharmaceutical industry, that is to be expected, I believe.
Okay. And so then you are looking to make a career change. Is that correct?
Well, I'm in the midst right now of going back to patient care. I miss my sweet grandmas bringing me cakes and cookies. Not that I need to be eating cakes and cookies, but I miss the cards and the hugs. And let me show you a picture of the grandkids. And I miss that connection, because when you form that connection, it's easier to administer care because you have that trust. So I'm looking to get back into that. And so, yeah, I'm looking at getting into locum work. So, yeah, I'm excited to get back into that side of the arena for sure.
So educate us, because I had not heard of locum. Well, I'd heard of locum work. The typical nurse is nurse, travel nurse. I've heard of locum work in the CRNA world and now in the MP world. Explain to us, what is that? What does that mean?
Well, I will preface it by saying I am a novice, since this will be the first time that I am doing this, but it's basically contract work and you have to have an agreement. For example, the locum that I'm doing, it's a 6-month assignment, but they're working with me. I'll be going to Michigan, but they're going to let me go up there every other week. I really can't move to Michigan at this point, but going up there every other week is feasible for myself at this juncture. So that's just kind of what it is. And you're like a travel assignment, you're away from home, but they typically pay for your travel. They pay for a car, they pay for hotel rooming situation. And then generally the hourly pay is significantly more. However, you have to be mindful that it's a 1099. Although there is one locum company that does do W-2. But this particular assignment I'm doing, it's going to be 1099.
Okay, and so did you just know to look for, I guess, what would be called a locum agency? Is that what they're called?
So you could Google them and it'll all spit it out. And then again, I was very specific. I want to do outpatient cardiology. You know, I want to manage hypertension and lipids and heart failure and coronary disease. And that's what's in my will. Cardiac clearances. Like, can you do cardiac clearance? Oh, that's all I used to do is cardiac clearances. So
Yeah. Of course, Tranise, this is not all you do. You're an entrepreneur. Tell us what you do.
yes. So shout out to my students at West Coast University, because that was where I was trying to teach EKGs as a formal class and the dean ignored me. So I have my platform called Dr. G, the NP. We opened that in June of 21. It's hard to believe that we're 3.5 years into this. So my mission is for people to get an EKG and actually understand it, feel comfortable with it, not to freak out. Don't let it intimidate you. The courses I matriculate you through very intentionally. And in the first course, it's called The Anatomy of an EKG. And I teach where to look, when to look, and what to look for. It's a 9-step systematic approach. That's our foundation. Once you master that, everything else I teach you, we're just adding criteria on. Because I'll give an example. LVH, left ventricular hypertrophy. The number one leading cause of LVH is hypertension. So imagine looking at an EKG and saying, oh my goodness, he has LVH. I wonder what his blood pressure is. And you ask your tech, what is his blood pressure? Oh, it's 160 over 100. Okay, figures. The second leading cause of LVH is aortic stenosis. So imagine again, same EKG. Oh my gosh, this is LVH. Hey, what's his blood pressure? Oh, they said it was 120 over 80. Okay, well, I better listen for a harsh systolic murmur at the second intercostal space right sternal border.
Right. So it's not just, do you know this rhythm? It's being able to critically think, okay, now you can read the rhythm. What does this mean to you? What are other implications? What else are we looking at?
Right. Because I'm going to ask you, are you about to pass out? Are you having breathing? Like, I may focus my interview on that if I'm seeing LVH criteria and his blood pressure is normal.
Yeah. I love this. We talked about this a little bit, beyond nursing school, even when you're on the floor, some education programs at some hospitals are better than others, but I feel that nurses in general would be happy to take an EKG class, and they're not going to offer it. So it's on you to find your own resources, Dr. G, and, learn it for yourself. And if nothing else, to make yourself more confident so that you don't feel like you're on the back end playing catch up and scared and alone and like, gosh, I don't know how to read this. I feel alone. I feel like I'm going to mess up. And most nurses, the overwhelming majority of nurses, they don't want to mess up.
Right. Absolutely. And to belabor the point, 2 other points. One, grouchies. That's what I call them. Grouchies.
Grouchies in nursing, stop.
Well, people who hoard knowledge annoy me. I will say, and I know that I'm not special when I make the statement, it's happened to all of us, but I've taken several tongue lashings and getting cussed out through the years for asking stupid questions. But if I don't know, I don't know. And last time I checked, my job is to make sure this person keeps their family together. My job is not to protect my ego. So if I'm asking a question, it's in the betterment of the patient, not because I'm wanting to annoy you or that sort of thing. And then 2, I just think we have to make it fun, right? I have the best clients in the world, hands down. I brag about the people in my program because not only are they fantastic, but I'm humbled that they allow me, just little old me, to show them this. And we have fun and I'm hands-on, and it's just so fulfilling to see someone's light bulb come on. Oh, I love that. When they're just like, that's what that means? That's what it means? Yes, that's what it means.
Well, and Tranise, you never know what you'll spark. Like if they take your class and they're like, I'm not bad at cardiology, I just never learned. And now I know. And oh, by the way, now I love it. Oh, by the way, this has opened all sorts of other possibilities that I might be interested in. We're talking about the EP lab and how they're like the EKG gurus. Maybe they would feel more comfortable in pursuing that or want to pursue it. More knowledge opens more doors. And even if the information wasn't for you, that's information. Hello? You never know until you try. Not to say that about EKG, but just saying in general, so many nurses are afraid to try different things. Well, what if I hate it? What if well, you'll be fine. So what if you do?
It adds to your repertoire. The other thing I mention to my clients or my students or anybody who even listens to me, Whatever you do, please do not blindly trust the computer interpretation. That is a recipe for disaster. The computer loves calling an old anterior myocardial infarction. It loves calling that.
Yeah, and they like to call bundle branch blocks. Everyone has a bundle branch block. Maybe they do, but they're calling it on everyone anyway.
It's like any rhythm that's irregular is a fib. It's like, I see the P waves. Not AFib. It's just the first degree, or maybe sinus arrhythmia, but it's AFib. That's another one. It loves calling AFib.
Yes, or this is just a bad EKG. The leads are not placed properly. I can tell by the way this thing looks. And that takes experience. Like I said, in the ER, yes, you know how to read EKGs. Yes, you are better at it than maybe someone on the floor that just doesn't see them as often. Not because you're smarter, but you just don't have as much experience with it. But then I also appreciated, if I don't know, hey, doc, you have to look at this anyway, so I'm going to give it to you. And then you get the opportunity to ask them to educate you. Really? You think it's that? Why? And, explain it to me. And not all nurses have that opportunity. I love that your class specifically fills a gap.
Well, thank you. In October, I was flown to Chicago and I spoke at the Illinois Society of Advanced Practice Nursing Conference. And I did 3 lectures for them, one in hypertension, and I did 2 EKGs. And the first EKG course I did was my basic one with the 9-step process. But the other one I did was my sneaky EKG course, because I really like showing people EKGs that at first glance, you think it's an issue, but it really isn't. Or one that you're like, oh, no, it's fine. But it's like, oh, no, there actually is an issue. So that lecture went well. And I just found out earlier this week, the New Mexico Nurse Practitioner Council, they're having me speak at their annual conference in spring, April, it's either the 8th or the 9th. So I'll be going to New Mexico to give that talk as well.
Dr. G is out and about.
Trying to be.
Well, what I love is that it gives nurses confidence. So when I do have to call the doctor, maybe I just got the EKG on my own because they were having chest pain, shortness of breath, and you're on the floor and you get the EKG. At least I can call the doctor or the nurse practitioner, whomever is on call, and say, hey, this is what it is. This is what I think, because now I have knowledge. This is what it's showing me. And you can step out a little, take another step forward instead of being like, I don't know what it says, which a lot of nurses feel like. And honestly, it's not their fault. They haven't received the education.
I tell my clients all the time, do not confuse ignorance with being unintelligent. All of us are smart. We can prove it. We have the papers to prove it. Just because someone never showed you something, that just means that you're ignorant. You don't know something because you were never shown. It has nothing to do with you as a provider, as a person.
So what would be your advice, if we'll circle back to the nurses that are like, hey, maybe I want to go to NP school and I do want to specialize in cardiology specifically. What would be your advice to them?
As a brand new baby nurse, I know there's a lot of assumptions. People say, oh, you can't start a specialty as a new grad. I personally don't believe in that. Everybody has their interest in their talents and they go where they go. However, I will say for me personally, doing med tele was a great start for me in cardiology, because the telemetry piece of it really gave me a good intro and a basic understanding of that 5 lead and just kind of learning the strips and learning the cadence and that sort of thing. I don't felt like I was thrown in, so to speak, kind of dropped into something, and it's kind of like survival of the fittest, if you will. I think my trajectory, I was able to really take my time and learn and feel and figure it out. I was a floor nurse for 4 years before I went back to grad school. So I had time to really see some things, do some things, and say, okay, this is what I want to do.
I think getting experience, well, especially as a nurse practitioner, is necessary.
Absolutely.
How much? I don't know. Would I say never? No, but just because there's so many varied circumstances, there's so many varied programs. That's why I like all nurse practitioners to say, okay, how did you become about this? Tell us your story. And then maybe someone is like that, or maybe that helps another nurse or nurse practitioner make a decision about what they want to do, because they're like, oh, okay. Or maybe it makes them reach out to you and say, hey, I want to take your class, or just follow you and see what you're doing and that sort of thing.
Absolutely. I think we all have to have that safe space, right? I mean, you're new and you're getting hit with a lot of lights and movement, and you know what I mean? Like, you're trying to catch up and learn your cadence. And it was like that for me, even becoming a new NP. I really didn't feel comfortable for the first 2 years because I became an MP in 2018, and come 2020, that's when I really felt good about what I was doing. And then 2021 is when I started my business because I felt that I had enough knowledge to be able to really show my expertise.
Yeah. Well, and I'm so glad that you said that you wanted to go to South Alabama because they had this specialty cardiac thing and they didn't accept you. And so you went to University of Arizona, but that's a great story because just because you didn't get the specialty, it doesn't mean it has to stop you. It's not the end of the world. You can still get to your goal and just go another route. Fine, that door closed. Fine. Where's the window? Where's the roof? I don't know.
Even within grad school, I had my challenges. My original DMP chair, she wanted my DMP topic to be atrial fibrillation. And she wanted it to be atrial fibrillation because she was writing a bigger research paper and I was supposed to be writing like part of it. And she knew I was interested in the African American population. So she wanted me to do AFib and African Americans. And I tried to do the research and I just wasn't feeling it. And so I had to have a very tough conversation to say, hey, look, I've identified someone else as my DMP chair and I don't want to do this anymore. And because of that, I had to start over, which pushed me back a semester in graduating. But in hindsight, it was the best decision for me. My DMP chair, he was fantastic. The whole committee was fantastic. They supported what I wanted to do in hypertension. And then, like I said, I was nationally nominated for the research. So it worked out the way it was supposed to work out.
I'm so glad you did that. There's this other gal that I follow because hypertension in African American men is a big, big deal. And it is not talked about enough. And there was this other gal I follow on social media. I don't know what her handle is, but one of her posts was like, men, African American men, you listen to me, you go get your blood pressure checked. Because it's such a big deal.
Absolutely, absolutely. I think one thing I will say about my career and advice I would give to someone is trust your gut. There were times where I tried to go against my gut, like me trying to do AFib instead of hypertension, just trying to be like, let me just hurry up, let me just get through this. But I think innately we know what's best. We just need to sit back and make sure we have all the pieces to the puzzle. That way we can put it together, right? And always do what interests you and be adaptable. When I was a brand new nurse, like I'm talking about undergrad days, I thought I was going to do pediatrics. No one couldn't tell me I was not going to do pediatrics until I had my pediatric rotation. And I'll never forget, this little boy had liver cancer. He's just a couple of years old. His parents abandoned him and the nurses on the floor adopted him. And he had such bad ascites. And I saw a lot on my pediatric rotation that deterred me from wanting to do pediatrics. Just children with cancer, little girl with a brain shunt for hydrocephalus, just a lot of things that I saw. I held a baby that was like a week old with tetralogy of Fallot. Just a lot of things that I was exposed to. I was like, I can't do this. And so I felt lost when I was so reliant on pediatrics. And in an undergrad, the cardiology test, I failed it. Are you really a nurse if you didn't fail a test in undergrad at some point?
Right. Please go fail. Are you winning at life if you haven't failed at something? Go fail more. Go try again. Oh, I failed. Well, get over it.
Right. Absolutely.
I'm like you with the kiddos because I love kids, but I never wanted to be a pediatric nurse because you didn't say this about yourself, but I get too emotional with these kiddos. No, give me grandma.
Well, that's what happened with me. I'm a kid myself, seeing these kids in my heart. Like every day after clinical, I was just torn to shreds. Yeah, that's another conversation for another day. But I think about those kids from time to time, and I just shout out to any pediatric nurses. Shout out to any pediatric oncology nurses.
No, you're going to find me at the clinic with grandma. Because where I worked in DC, it was massive campus. It was Washington Hospital Center, it was the VA, and it was Children's Hospital, all on one big campus. Washington Hospital Center had 900 plus beds, and we had no children. Sometimes parents would want to bring their children over, and they're like, no, you need to go next door. And then we would escort them next door. And so for the first several years of my career, well, at Georgetown, they saw kids, but just not many. I just didn't see many kids, and I didn't want to. I never wanted to because I just always got emotional with the kiddos. And then when I came over to California, I worked in an ER, and it was mixed children and adults. Still, our adult population far exceeded our kids because we had CHOC, which is Children's Hospital of Orange County, up the road. But still, these cancer diagnoses and the drownings.
Yeah, I'm right there with you.
You're going to find me like, where's the fan so I can blow at my eyeballs so the tears stop? Can't do it.
The experience was just so jarring for me and scarring. I know most nurse practitioners are family nurse practitioners. I'm adult gerontology, acute care.
Oh gosh, Tranise, well, I really appreciate all of your experience. I mean, what a road. And I hope nurses are out there listening. You know, hey, if you're interested in cardiology or becoming a cardiac NP, hey, start in med-surg telemetry. A lot of nurses these days are like, oh my God, I started med-surg. Med-surg is great. It's fine. Take your little step over telemetry if you want to, and then take another little step over here, and then maybe step over here if you want. And it's okay. And so I'm so glad that you shared. That's why I always want the nurses, tell me your journey. And sometimes nurses know exactly what they want to do. It's pediatric oncology. It's where they started. It's where they're going to finish. It's where they're going to die. Fabulous. Sometimes people make a million changes. Great. Sometimes people go on to get their master's or their DNP, and fabulous. Tell us all about it. I really appreciate you coming on. We get to the fun part of the interview. Now, when I had Black Sheep Nurse Podcast, I didn't do this. But I just really feel like people want to know you. Like, who is this actually talking to me, and do I know them? So here's some fun questions. Now, you said you were an athlete.
Yes.
Do you do CrossFit?
I do not do CrossFit, but I am an amateur powerlifter right now.
That's what I thought it was. So this question applies to either one. If I had to torture you with cardio, what would you rather do for the rest of your life? An elliptical or run?
Oh, that is an easy answer. Elliptical by far. I have had 5 knee surgeries and a ruptured Achilles all on the same leg.
Is that from your basketball days?
Yes.
Okay. Did you play in college?
I did not play in college. I did not. I played through high school, tried to walk on, didn't work out. And then I played in adult leagues. And the last time I played, I had a knee surgery actually last year. My husband, he was like, you shouldn't have done that, but that's neither here nor there. I was at the gym, minding my own business. The guys asked me, did you want to run? I mean, I was shooting, I was minding my own business. They approached me.
You're a competitor in your heart. What were you supposed to say? Come on, mister.
Right.
Okay, well, are you a sports fan?
Absolutely.
Football or baseball?
I'll say football, but my main sport is basketball, particularly the WNBA.
Okay, what's your team?
Oh, Las Vegas Aces.
Okay. So I grew up, when I was in college, I went to Texas Tech. That was my first degree in Spanish. No sight of nursing around. Anyway, that was Cheryl Swoop's days.
I was about to say, Cheryl Swoops went to Texas Tech.
Yes, she did. And I watched her play.
She's amazing. She's a living legend, for sure.
That's what I was going to say. Did she play for the USA Olympic team?
Absolutely, she did. And she was part of the Houston Comets 4-peat. When I was a kid, my parents, we used to fly to Houston to go watch the Comets play. It was like a rock show there. The place was rocking.
She was a legend in, this is a whole other topic, talking about women's basketball. But it's so interesting to me how, like, I played basketball in high school. I was not good, but I played all 4 years. I did not walk on anywhere. I walked off the court. But I love to play. I just like to be active. But women's basketball in high school was popular. It was really popular. And in college, maybe it was because of Cheryl and the team that they had out at Texas Tech, it was really popular. It filled stadiums. This is a whole other conversation, but I loved playing. I loved watching. We went to every game. Okay, if you're going to splurge and buy yourself something, what are you going to buy? Like, are you a foodie or you need more workout equipment?
Do moms know how to splurge?
They should. Let me tell you, my mom friends love to beat themselves up. And I'm like, no, not with me or not. Let's spoil you.
I'm pretty low key. I do like to eat. I mean, I'm from New Orleans. I love me a good steak.
That's another question on my list because I knew that you were an athlete, or at least I knew that you worked out. I thought it was CrossFit, but CrossFit has some powerlifting elements. So maybe that's why I thought that. What is your favorite protein source?
We're going to have it tonight, some filet. I love filet mignon.
It is my favorite.
Can't get enough of it.
I cannot get enough of it. You can do all sorts of compound butters on it.
Well, my husband, every Saturday, he makes filet mignon tacos. It's fabulous. He marinates it. It's beautiful. And it's not a cheap meal because we get the whole wheat, low carb wrap thing, put it on there, put a little sauce on there, chops up the bell pepper and all. Oh, yeah. Every Saturday.
I'm going to map myself over. Oh, we won't be in Michigan. Okay, so final question. What is your favorite cardiac rhythm?
Oh, what is my favorite rhythm?
I have my favorite.
I love a biparticular block. All right, you probably saw my eyes light up when I said that too.
I'm glad.
I love a biparticular block. I love some LVH. I like the biparticulars because they're sneaky. But like inherent rhythm, everybody's sinus. That's so boring. I really like an ectopic atrial. It's kind of a little spicy, but generally they're fine. It's not anything to get excited about. Flutter looks cool. It looks cool, but you gotta work. Flutter's gonna make you work. But ectopic atrial is a cool rhythm, but you don't have to freak out over it.
My favorite rhythms are probably because they're the easiest to recognize. And so nurses out there who are not cardiac nurses will understand. I like a flutter. I like winky bach, bach.
Longer drop. You got a winky bach.
I can find it on my test. Well, Dr. G, Tranise, thank you so much for coming on. Remind everyone where they can find you on IG, your website, all that good stuff.
So on Instagram, my handle is Dr. G the NP, so DRGTHEMP. The website is the same, drgthenp.com. On LinkedIn, it's just Tranise Goodlow, just my name, that's it. And Facebook, it's drgthenp.com.
Gotcha. Okay. Well, thank you so much for coming on, doing this interview. I really appreciate it, and I learned so much.
Awesome. I really appreciate you, Erica. Thank you for your platform. Thank you for having me as a guest. I really appreciate you. Keep shining bright and doing the wonderful things that you're doing.
You know what? Hey, Rebels, before you go, don't forget to check out our merch. From witty apparel to stickers and hats, we've got it all. Head to our shop at shoprebelnurse.com to find your favorites and use code RN15 for an exclusive 15% off. Again, that's shoprebelnurse.com. And thank you for supporting Rebel Nurse and for being here.